Okay, now that the recording started, I guess we'll go ahead and get started. Really want to welcome everybody again to the new academic year, and I'm delighted to be here to talk to you about atrial fibrillation. Hope that we'll be able to review some important information about atrial fibrillation and really discuss some new directions and new ways to think about atrial fibrillation. So thank you all for coming. Okay, so first off, why is atrial fibrillation important? It's a highly prevalent lifetime risk, and we'll talk about that in a few minutes. For those of you who don't know what that is, for developing atrial fibrillation is approximately 25% once you reach the age of 50. Affects 5 million Americans, projected to affect over 12 million by 2050. Atrial fibrillation tremendously impacts quality of life. It increases mortality, and it has a substantial stroke risk. It turns out that 15% of strokes in the United States are attributable to atrial fibrillation. So this is really a very critical and important problem that we need to understand and hopefully learn how to evaluate and treat. This is an old slide from 1995, but it gets the point across. Atrial fibrillation is predominantly a disease in the elderly. You can certainly see it in people in their 40s and 50s, but you know, peaks at around age 70. So this is a slide from Don Lloyd-Jones' paper looking at lifetime risk for atrial fibrillation. So this is based on the Framingham data. And what each curve represents here, so this red curve here represents if you get to the age of 40 and you've not had atrial fibrillation yet, what is the risk that you'll develop atrial fibrillation before you die at various ages. And you can see it starts to increase, and then it plateaus around age 90 at around 25%. And you can follow each one of these curves. If you get to the age of 50 and you've not yet had atrial fibrillation, you have about a 25% chance of getting atrial fibrillation before you die. And 60, 70, 80, it doesn't change. And essentially, those data are the same for women. It's maybe 23% instead of 25%. So pretty much once you get to the age of 40, you have a 25% chance of having atrial fibrillation before you die. This is data from Olmsted County, from the Mayo Group, showing the effect of atrial fibrillation on mortality. So this is now comparing it to a Minnesota expected population without atrial fibrillation. So this is looking at first diagnosis of atrial fibrillation. So you can see, obviously, there's an acute drop here. So there are people who are acutely ill. So they recalibrated the graph to do sort of a landmark analysis starting 4 months after the diagnosis of atrial fibrillation. And even then, when you start 4 months after the diagnosis of atrial fibrillation, you can see that there's substantially worse survival among those with atrial fibrillation than matched patients. Hazard ratio is 1.66. So that's a substantial increase in mortality associated with atrial fibrillation. And then here's the stroke epidemiology. There's 5-fold increased risk of stroke in patients with atrial fibrillation. 15% of strokes are attributable to atrial fibrillation. Stroke severity is actually worse with atrial fibrillation. And incidence of all-cause stroke in patients with atrial fibrillation is about 5%. That's averaged over a lot of different risk scores. All right, so the questions that I want us to ponder this morning are the following. What is atrial fibrillation? What is atrial myopathy? And do we treat the atrial fibrillation, the atrial myopathy, or both? Now, if there are those of you in the audience who know the answers to those questions, you're way ahead of me. So I would invite you next time to come and give this talk But if you've been around for a while, like me, and you don't know the answers to these questions, which I don't, one of the things we should all ask ourselves is, why don't we know the answer to those questions? And for those of you who are just really starting out in the field, you can start to think about what the important things are to learn to be able to answer these questions. All right, so let's start with some simple ECG examples here. So I can explain what I mean. So what is atrial fibrillation? So I think if you ask, a lot of people, what is atrial fibrillation? They describe it to you in many different ways. Some people say, well, it's an irregular rhythm. Some people would say it's a rapid, chaotic rhythm in the atrium. And I'm sure we can come up with a bunch of other descriptors. But here you see 4 different ECGs from patients with atrial fibrillation. And you're looking at V1 recordings. And what I'd like to point out to you is that, excuse me, even though they're all atrial fibrillation, there are easily distinguishable ECG characteristics among these 4 different patients that we really don't know how to classify. So for example, if you look at the first 2 here, you look at this box here, you can look in here and you can count that there's 1, 2, 3, 4, 5 fibrillatory waves in this one box. You go to this next example, the same size box has only 3 fibrillatory waves, right? So we see already that there's differences in rate of atrial fibrillation that we don't really account for. Obviously, this second tracing has a lot larger amplitude F waves, a lot more organized than what you see in the first tracing. And then similarly, if you go to the bottom 2 tracings, here you see in this box, you see 3 fibrillatory waves, and here you see 2 fibrillatory waves. Here again, you see very low amplitude F waves, you can barely see them. Here you can see them much more prominently. So we see that there are differences, but we really don't know how to evaluate them and what they mean. And that gets to the point of how we classify atrial fibrillation. And certainly on ECG, people talk about coarse and fine atrial fibrillation, but do we understand what the pathophysiologic implications of coarse versus fine atrial fibrillation are? We know, does it have any implications in how we treat the atrial fibrillation? The answer is maybe, but we just don't know. We also can classify atrial fibrillation as primary versus secondary. For example, the patient who has CABG surgery or pneumonia and then gets atrial fibrillation, once the inciting event resolves, the patient no longer has atrial fibrillation. We certainly classify by type, whether it's paroxysmal, persistent, or chronic. And for our incoming fellows, if you don't know the definitions, you should look up the most recent guidelines and be able to differentiate what these 3 different types are. We also classify atrial fibrillation by symptoms, whether it's silent or symptomatic. Certainly by heart disease, whether there's lone atrial fibrillation or concomitant heart disease. We'll also talk about some autonomic types of atrial fibrillation, like vagal atrial fibrillation. But you'll notice from a pathophysiologic basis, there's only really 2 of these classifications that give us any help on the pathophysiology of the atrial fibrillation. One is the autonomic, obviously vagal AF gives you an index of the pathophysiology, but this is a very small percent of all atrial fibrillation. And then obviously secondary atrial fibrillation gives you the pathophysiologic basis for that kind of atrial fibrillation. All of these other classifications give you no information about the type of atrial fibrillation or the underlying atrial fibrillation. All right, so let's move on to another way to look at atrial fibrillation. How about in terms of the underlying electrophysiologic mechanism? Well, unfortunately, the best I can do for you in terms of that is to show you this cartoon. And that's what I have to show you, is a cartoon from 2007 from U. Hawkins. So what we're looking at here is the a posterior view of the left atrium. You can see the pulmonary veins extending here. And what we see here in this cartoon is a depiction of many different kinds of potential mechanisms that have been proposed to be responsible for atrial fibrillation. So these stars are rapid focal firing in the pulmonary veins. These represent micro reentry. These yellow areas represent autonomic ganglia and whether those are involved. There could be these things called rotors. And again, we don't know which patients have which mechanisms, is there one predominant mechanism? Do they combine? This is still completely unresolved. So that brings us to diagnostic evaluation of atrial fibrillation. So you say, all right, maybe it's not so bad. We can't classify atrial fibrillation on a pathophysiologic basis, but we really know what we're doing, right? We know how to evaluate patients with atrial fibrillation. And in fact, the 2014 atrial fibrillation guidelines do tell us what the initial diagnostic evaluation is for atrial fibrillation. It's a history and a physical examination, an electrocardiogram, an echocardiogram, and blood tests for thyroid, renal, and hepatic function. So this diagnostic evaluation for atrial fibrillation has not changed for 30 years. That means we have not learned anything about the diagnostic evaluation of atrial fibrillation in that time period. And just as a comparator, think about all the diagnostics that have changed and evolved in cancer, and the implications that those diagnostics have had on therapeutics. We're still at ground zero. We haven't changed in 30 years. But we're very good at doing what we've done 30 years ago. All right, so one of the things I wanted to go through with everyone is something that's actually very, very puzzling in terms of what is atrial fibrillation. And perhaps one of the biggest masqueraders, the biggest confusing entities that I certainly find fellows have a lot of trouble with is differentiating atrial flutter from atrial fibrillation. This first became apparent to me about 15 years ago or so when I was still at Northwestern. I was on the electrophysiology service as attending in July with a brand new cardiology fellow. He just finished residency at Northwestern, was very confident in his ECG reading skills. And on rounds, we'd see patients with atrial flutter, we'd see patients with atrial fibrillation, and almost 100% of the time, if the ECG showed atrial fibrillation, he would read it as atrial flutter, and if it showed atrial flutter, he would read it as atrial fibrillation. And I said to myself, how could this be that, with all this training, we don't have any good criteria to differentiate atrial flutter from atrial fibrillation? And by the way, this fellow is now an excellent practicing electrophysiologist. But anyways, so we look at ECGs like this, and people have trouble classifying this as either atrial flutter or atrial fibrillation. So we decided to undertake before that, the question is, does it really matter to differentiate atrial flutter versus atrial fibrillation? And the answer is it matters quite a bit from the electrophysiologic perspective and from the patient perspective. Catheter ablation for atrial flutter is first-line therapy. It's got over 90% success rates, and it's got very low complication rates. That's a marked differentiation from the situation for atrial fibrillation. So correctly making the diagnosis of atrial flutter versus atrial fibrillation is actually extremely important. So in order to develop our criteria, we had to have a gold standard, and the gold standard we got was from the electrophysiology lab. So we took 50 patients who had electrophysiologic testing and proven to have atrial flutter, and 50 patients who had electrophysiologic testing proven to have atrial fibrillation. You can see some of the key characteristics. So the cycle length of the atrial flutter was 254 milliseconds, whereas the cycle length of atrial fibrillation is much faster, so it's shorter cycle length, 171. Cycle length variability in flutter is very low at 1.4 milliseconds. In atrial fibrillation, you have much more cycle length variability. So these are the things that you would expect to see in atrial flutter and atrial fibrillation. And we looked at a lot of the different criteria that you could find in ECG textbooks at the time. We looked whether there were F waves in V1, F waves in the frontal plane, the classic sawtooth F waves that people say you should look for to make a diagnosis of atrial fibrillation. We looked at the atrial rate. We looked at the ventricular response, whether it was regular or partially regular. So the way to think about this, we all know we use terminology in irregularly irregular ventricular response for atrial fibrillation. So anything that's not irregularly irregular has to be either regular or partially regular. So it's the sort of the opposite of irregularly irregular. And then finally, F waves in V1 in the frontal plane. And you can see we have a range of sensitivities here, up to about 98%, but this didn't have a lot of good specificity. And we have a bunch of criteria that have good specificity, but the best here is just F waves in the frontal plane. It has sensitivity of only 92%. So then we went ahead and we combined the criteria, and we combined the regular or partially regular ventricular response with each one of these. And it turns out that if you combine this ventricular response with F waves in the frontal plane, so this is not looking at V1, you get a sensitivity of 90% and a specificity of 100% for the diagnosis of atrial flutter. So what this is telling you is if you look at F waves in V1, you actually reduce your sensitivity. So the advice here is ignore V1 when you're trying to make a diagnosis of flutter. It can actually make you more confused and misdiagnose than help you. So it's nice that we had these new criteria, but we wanted to sort of now evaluate and validate these criteria. So we took 100 ECGs that were read as atrial fibrillation by cardiologists and 100 that were read as atrial flutter. This is again taken from our Muse database. And 3 of us in the EP group, we read all of these ECGs. And then we compared our reading, the cardiologist reading, and then the criteria-based reading. And what you can see here is that the concordance between the cardiologist reading and the electrophysiologist reading was only 84%, which is pretty poor when you think about it. We should have a pretty high concordance. If you look at the concordance between the cardiologist reading and the criteria-based reading, it was also only 82%. But when you looked at the concordance between the electrophysiologist and the criteria, it was 94%. That means that the electrophysiologists overrode the criteria only 6% of the time. But we wanted to then expand this even further and see how the criteria work out in the real world. So we took those same 200 ECGs that we had that were read as atrial fibrillation and read as atrial flutter, and then we added another group of 100 ECGs that were read in the database as atrial fibrillation flutter. I will tell you that there is no such diagnosis as atrial fibrillation flutter. This is not a real rhythm. There may be a very rare exception to this, but this is not a rhythm. Patients can be in atrial fibrillation, they can be in flutter, but typically they're not in fibrillation flutter. What this is a manifestation of is the difficulty of the cardiologist in making a determination whether the rhythm is fibrillation or flutter, and so they put a diagnosis that indicates both. So these are basically very, very hard ECGs to determine. And then we gave all 300 ECGs to 10 internists, and we asked them to read them. One group, this group of 10, was not given the criteria. And then we gave another group of 10 internists the same 300 ECGs, but we gave them the criteria to differentiate atrial fibrillation from atrial flutter. And this is what we found. Not to anyone's surprise, if one looks at the internists in the blue who were not given the criteria versus those that were given the criteria, the ones given the criteria did much better than those without the criteria in terms of concordance with the criteria-based diagnosis, or with the electrophysiologic-based diagnosis. So what's very interesting here is even though the internists were given the criteria, they chose to override the criteria by almost 18% of the time. So there is a strong predilection to not rely on the criteria, but to rely on your own diagnostic skills to make this differentiation. And most of the time when you do that, you're going to be incorrect. So let's go back to this initial ECG that I showed you. I hope you were all mentally thinking about what the diagnosis was. But this is in fact what happened when we went through the process with this ECG. So in the Muse database, the cardiologist originally read this as atrial flutter. The 3 electrophysiologists all read this as atrial fibrillation. By criteria, this is atrial fibrillation because the ventricular response is irregularly irregular, and there's no clear F waves in the frontal plane. The internists without the criteria, 7 out of 10 read this as atrial flutter, but all 10, when given the criteria, read this correctly as atrial fibrillation. So here's an example of an ECG, and this is a patient that one of my colleagues, an electrophysiologist, saw in consultation, made a diagnosis of atrial flutter, asked me to do an ablation of this patient, and we brought this patient to the EP lab to do an atrial flutter ablation. But lo and behold, when we brought this patient to the electrophysiology laboratory, these are the intracardiac recordings here. And what you can see is that these intracardiac recordings are not very regular. They actually show a lot of irregularity. If you look at the coronary sinus, sometimes it's proximal to distal, sometimes it's distal to proximal. So this is more characteristic of atrial fibrillation than atrial flutter. So even though we both thought that this was atrial flutter coming into the electrophysiology lab, it turned out that this was atrial fibrillation. And if you go back and you apply criteria here, again, the ventricular response is not regular or regularly irregular. And then if you really look carefully at some of the F-wave morphology, you can see that there are some changes, particularly here in AVF. So it's not consistent F-wave morphology. So even going retrospectively, the criteria here were actually more correct than the EP diagnosis. Now, there are definitely counterexamples. So this is an example of a patient with atrial flutter with rapid ventricular response. You can see it's clearly a regular ventricular response, but you can't see F waves in the frontal plane because the F waves are buried in the T wave and the QRS complex. So you have to certainly be aware of counterexamples. And here's another very intriguing counterexample of atrial flutter where you could see very clear, consistent F waves, but the ventricular response is irregularly irregular. And but this does not happen very frequently. So I hope that was helpful in terms of understanding what is atrial fibrillation and certainly differentiating that from atrial flutter. So I'd like to move on to the next question, which is what is atrial myopathy? And essentially, and people call this atrial cardiopathy. It's now a very common entity for people to be discussing. This is the long ignored chamber, the left atrium. And it's basically no different than a ventricular myopathy. We're talking about dilatation, dysfunction, and fibrosis. Now, I'm not going to say a lot about dilatation, and the reason for that is we have had echo for decades to look at atrial size, and although we do look at it, and it is something that's been available for a while, when you think about it, again, it doesn't really factor all that much into our clinical decision making for many things. So, for example, the CHADS FAST score, which is our risk score for stroke, has no line item in there for atrial size. So this is probably not going to be a very good marker of atrial myopathy if we want to use it as a guide or a diagnostic guide or therapeutic guide for atrial fibrillation. So one of our local experts on atrial myopathy is Harold Rivner, who spent quite a while delving into the various ways to look at this. And this is a sort of a timeline for how one develops atrial fibrillation. So again, just like coronary disease, somebody manifests with an acute myocardial infarction. That is not the first time that that person had coronary disease, right? That coronary disease has been building up for decades, probably. And the same thing is true for atrial fibrillation. Although we see the patient when they develop symptomatic, or if we find them serendipitously with asymptomatic atrial fibrillation, although we see them at this time point, there's been many, many years, perhaps even decades, of underlying disease progression that has allowed the atrial fibrillation to develop. So if we start out with, normal atrium, there are many different mediators here that can influence the atrium: aging, epicardial adipose tissue, oxidative stress, inflammation, pressure, and volume overload. These can lead to fibrosis, dilatation, dysfunction, and in a feedback loop here, we can develop further substrate for atrial fibrillation, and then here we mark having the preclinical atrial fibrillation substrate, and then this can manifest either as atrial fibrillation or directly as stroke. And those are the clinical manifestations of atrial fibrillation. But we have to start thinking about the progression of atrial fibrillation over time, because just like with coronary disease, we prefer to intervene before the patient has a myocardial infarction. Same is going to be true with atrial fibrillation. We'd like to intervene and prevent the atrial fibrillation from ever developing, rather than waiting for the patient to develop atrial fibrillation. So it's a new paradigm, a new way of thinking about this in terms of diagnostic and therapeutic approach. So I'm not going to go through all of the different ways to look at atrial myopathy, but there are several, and I would encourage you to read Harold's review article that's coming out shortly in Arrhythmia and Electrophysiology Review. But there are ECG methods that have been described to look at atrial myopathy, so looking at the P-terminal force in V1. There are MRI techniques to look at atrial fibrosis. This is really developed by Nasir Marouche at the University of Utah. And you can see here various different MRI exams of the left atrium. Just look at it from the posterior wall. The blue is normal tissue and the green is the fibrosis. And they define the percent enhancement here as the indicator of how much fibrosis the patient has. You can see here Utah 1 has very low fibrosis, whereas Utah 4 has over 35% enhancement or fibrosis. There's a lot of controversy about this technique. MRI has very limited spatial resolution for the atrium, and so it's not widely used yet, but I think we'll be seeing more of this as time goes on. This is also a posterior view of the left atrium. You can see the pulmonary veins here, but this is now taken from the electrophysiology laboratory, and now we're looking at a voltage map of the left atrium. So this is the voltage scale. So purple and blue are probably normal voltage, and everything else is low voltage. Red is almost no voltage. And you can see in this posterior wall of the left atrium, you have a lot of low voltage areas and almost no areas of normal voltage. In an anterior view, you see that you have a little bit more normal voltage in the septal area. So again, voltage could be a criteria for defining the myopathy, but again, it's not very it's certainly not non-invasive. It's not an easy way to characterize myopathy in patients, in a broad group of patients. So this is sort of a summary of a lot of different techniques that are actually all available right now. So we have a lot of surface ECG techniques that can be used to define either the fibrillatory waves or the P wave. We have biomarkers that can be used to evaluate atrial fibrillation, MRI, which can be used to look at fibrosis. We're using MRI to look at the 4D flow characteristics, so we can actually measure flow in the left atrium. CT or MRI look at epicardial fat, and we'll talk about this moments. And then echo techniques looking at left atrial strain analysis. So we have advanced techniques to evaluate the substrate, to evaluate the myopathy, but we don't know which ones are important and which ones are actually modifiable. And that's actually the big question. Can we modify the substrate once it occurs? All right, so we'll go on to the next part here, which is, do we treat the atrial fibrillation, the atrial myopathy, or both? And I think this is a fairly novel question because, again, for the past 30 years, we've mostly been treating the atrial fibrillation. There's very little, as far as I know, that is treating the atrial myopathy. And so there's obviously an age-old question in terms of treating the atrial fibrillation, which is, do we restore sinus rhythm or do we just go with rate control? And that's a huge discussion. And I'm not going to have time to really delve into that today, but I'm happy to do so at another time or one of my colleagues. But I do want to leave you with a little bit of a biased response in terms of what we should be doing with our patients with atrial fibrillation. So the question is, if atrial fibrillation is associated with an increased risk of stroke, which ranges between 65 and 126% based on published literature, and it's associated with an increase in mortality risk of 60 to 90%, how is it possible that prevention of atrial fibrillation would not be associated with benefit? Okay, this is sort of a rhetorical question, and this has been studied. And for the answer, I will refer you to the most recent published randomized clinical trial that addresses this, which is the Cabana trial. If you haven't read it, it's definitely worth reading. You will see that the answer is not 100% clear. It still remains murky. But I would tell you that the overwhelming accumulation of data does seem to suggest that there's a benefit to maintaining sinus rhythm, and that benefit is particularly enjoyed among certain subgroups, like patients with heart failure or younger patients with atrial fibrillation. So, although we don't have a definitive answer, we are accumulating a lot of data that suggests that maintenance of sinus rhythm is important and does provide important clinical endpoints. And of course, this does not even address the symptomatic issue. Obviously, patients who have symptoms derive benefits from maintenance of sinus rhythm. So we're going to leave that particular topic now and talk a little bit about the treatment for atrial fibrillation. And this was, I think, really a revolutionary change that came in the late 1990s. This is a pathologic specimen showing the border zone between the left atrium on the left here and the pulmonary vein on the right here. And what you can see is the muscle tissue of the left atrium extends into the pulmonary vein, sometimes up to a couple centimeters. And this muscle tissue in the pulmonary vein can actually be can actually fire and lead to pulmonary vein tachycardias. So this was first discovered by Michel Hasseguer in France and published in the New England Journal in 1998. And this is a figure from that paper. So you see here the ECG recordings. So this is first beat is sinus rhythm, and then the patient goes into atrial fibrillation. This happens to be a recording made from the right inferior pulmonary vein. And what you see here are two potentials. This first potential is an atrial potential, and then this second potential is what we would call a pulmonary vein potential. So it's a separate activation of that muscle tissue in the pulmonary vein. And you'll see that the way this tachycardia starts, this asterisk here, is the pulmonary vein tachycardia. It's this from the right inferior pulmonary vein, and then this degenerates into atrial fibrillation. So the pulmonary vein tachycardia is the focus of tachycardia that leads to atrial fibrillation. And it's this observation that led to the explosion of catheter ablation for treatment of atrial fibrillation, initially for paroxysmal atrial fibrillation, and a variety of different iterations. But for the most part, the approach for catheter ablation for paroxysmal atrial fibrillation is to electrically isolate the pulmonary vein tissue from the rest of the left atrium. If you electrically isolate it from the rest of the left atrial tissue, any focal firing that you see in the pulmonary veins can't activate the left atrium and lead to atrial fibrillation. And this is just to show you a number of different randomized studies comparing drug therapy to catheter ablation therapy for patients with paroxysmal atrial fibrillation. And you can see the success rate for catheter ablation for treatment of paroxysmal atrial fibrillation is in the 70 to 80% range, whereas the success rate for drug therapy is substantially less than that. So for paroxysmal atrial fibrillation, catheter ablation has emerged as really a very, very good therapy for treatment, acknowledging that maybe 20% of patients may not have resolution of their atrial fibrillation with just pulmonary vein isolation. And that's again a topic for another day on why that might be. Now, this story is not the same for persistent atrial fibrillation. So this is from a meta-analysis published in 2018 in Europace. And what you see here is, again, we don't have to worry about what's down here, but just to let you know, these are a variety of different ablation techniques to treat persistent atrial fibrillation. The most basic one is the pulmonary vein isolation, which is the same technique that we use for paroxysmal atrial fibrillation, and then these are all add-ons. So they do pulmonary vein isolation and add on other things. What you'll see here is the single procedure success rate in the blue for pulmonary vein isolation or pulmonary vein antrum isolation is about 50%. And none of the other techniques do any better than that. So 50% for a fairly involved technique is really not a great result. And that's why there's been a proliferation of attempts to try to improve that with these other techniques. But it doesn't appear that more ablation gets you more success. If anything, more ablation sometimes seems like it gets you less success. Having said that, though, when you do multiple procedures, sometimes you actually do see an improved success rate. So now going back to our treatments for atrial myopathy. So the question is, which of the following are established treatments for atrial myopathy? And it's too bad I don't have an audience response system, but if you think amiodarone, digoxin, diltiazem, catheter ablation, weight loss, have any of them had any suggestion to be a treatment for atrial myopathy? I hope some of you are thinking, well, I don't think amiodarone, digoxin, diltiazem, or catheter ablation actually treats the atrial myopathy, but what about weight loss? Maybe I want to hear about that, and we'll let you know about that one. So there is a lot of emerging data on the importance of weight loss and risk factor modification for treatment of atrial fibrillation. So this is the one of the key trials that was published in this area in 2013 by the group from Australia. And they took 150 patients with BMIs of over 27 who had symptomatic atrial fibrillation. And they had two groups, an intervention group, which was a physician-led weight loss program, or a control group, which was self-directed general lifestyle measures. So that's basically doing what most of us do in the office, is saying, you know, you're overweight, you need to work on losing weight. So they had a median of 15 months of follow-up. You can see the characteristics here. Patients were around 60. BMI was around 33. And lo and behold, if you look at the BMI here in the versus the control group, you see that the intervention group had a much more significant drop in their BMI. But look at what happened to their symptom burden score and symptom severity score for atrial fibrillation. Those patients who had the weight loss, or drop in the BMI, had a much greater reduction in symptom severity and symptom burden score with atrial fibrillation. The investigators went on and did another trial, which is the ARREST AF cohort study. And what they did here is they took 281 patients who were having catheter ablation, identified those that had BMIs of over 27. And what they did here was not a randomized study. They offered them risk factor management as they had in the prior study. Only 69 of the 165 accepted. 96 said, no, just do the ablation. I don't want any risk factor modification. And these are their results here. We'll focus just really on this panel. This is the single procedure AF-free survival. In the red, you'll see the patients treated with the risk factor modification. And here you see the patients in the control group that just had general lifestyle measures told to them. You can see the dramatic difference here at 2 years, okay? Almost a doubling of the success rate for catheter ablation when you do risk factor modification. This is another study from that group, now looking at the sort of dose response of weight loss. So they divided their patients into 3 groups here, those that had less than 3% weight loss, 3 to 9% weight loss, and over 10% weight loss. I won't go through with you all the characteristics here, but what's important to see here is the more weight loss you have, the better you actually do in terms of total atrial fibrillation-free survival. So this is a real phenomenon. So one more paper from that group that I wanted to share is what they call the reverse AF study. And here, I think this is really a sort of mind-boggling study where they talk about the prevention and regressive effect of weight loss and risk factor modification on atrial fibrillation. So again, they define their 3 different weight loss groups here, less than 3%, 3 to 9%, and over 10% weight loss. You can see this is now a fairly small study, a little over 100 patients in each group. So at baseline, you can see the distribution here between paroxysmal and persistent atrial fibrillation. They're somewhat different in each of the groups, but not all that different. And then they had about 4-year follow-up in this study. They all started off with high BMIs. And they looked at how the atrial fibrillation changed. So paroxysmal to persistent would be sort of progression. Persistent to paroxysmal would be regression. No change, obviously, is no change. And AF-free, obviously, would be having no atrial fibrillation would be a dramatic improvement. And you can see here in the patients who had no weight loss, if you look at the purple, a lot of progression here. Some weight loss, less purple. A lot of weight loss, very little purple. In terms of regression, yellow. Not much here, a little more here, a lot here. And then look at AF-free. And again, these patients were all getting concomitant treatments for their atrial fibrillation. So it's not just the weight loss, but you can see here, there's a small percentage in follow-up that have no AF, more here, and then over half the patients here have atrial fibrillation. And if you look at just the number of patients that had no AFib ablation, you can see here 13%, the middle weight loss 22%, and here 45.5%. So, and this is total freedom from AF with no AFib ablation. So this is actually a dramatic effect on atrial fibrillation. And as you'll see, this is something that that actually is very, very important. So I think it's important for us to ask how weight loss or risk factor modification works. Is it the weight loss itself? Is it perhaps effects on diabetes, on sleep apnea, hypopnea? Again, we don't have the mechanism, we just have the observation. All of these studies that I've shown you were done in Australia, and it's a legitimate question to ask whether it will work in the United States. And I think we have to understand what the mechanism is for the weight loss. Is it reduction in visceral adipose tissue, in perhaps epicardial or left atrial adipose tissue? And I think another important question that we're addressing is, can be reproduced with drug therapy? So let's talk about epicardial fat and atrial fibrillation for a minute. So epicardial fat basically is just fat that sits on the myocardium. There is no separating fascia between the fat and the myocardium. So the fat can directly release adipose cytokines into the myocardium. These can promote fibrosis and inflammation, and actually could be mediators of development of atrial fibrillation. There's a large literature on the effects of epicardial fat on atrial fibrillation, and this is just one example from the Framingham cohort. They showed that pericardial fat was an independent multivariate predictor for the development of atrial fibrillation in follow-up. The hazard ratio of 1.3. This is another set of studies looking at the role of epicardial fat in predicting outcome after catheter ablation. So these are the largest studies that are out there, and they measure epicardial fat in a variety of different ways, either by echo or by CT. And you can see the hazard ratios are significant for the prediction of recurrent atrial fibrillation based on the amount of epicardial fat. So again, it seems to be that the visceral fat on the heart may be implicated here in the development of atrial fibrillation, and also in the response to catheter ablation. So we are fortunate to have Gianluca Cavellis on our faculty here, who is an endocrinologist and has had a long-standing interest in epicardial fat, and has done really a large amount of research in this area. This is one of his studies, and what he's identified is that the epicardial fat expresses glucagon-like peptide 1 and 2 receptor genes. So you'll see why this is important for us as we talk about this. GLP-1 agonists are used for treatment of diabetes and obesity. So liraglutide is one of these agents. And again, from another study that Gianluca did, he showed that administration of liraglutide, he measured the epicardial fat at 3 months and 6 months, and you could see dramatic reductions in epicardial fat related to liraglutide, which you did not see with metformin. So it does appear to be an agent that can reduce epicardial fat, and now we need to know whether that means anything. And that gets to the last part here, which is to tell you about our clinical trial looking at this. It's called the LEAF study, and it's liraglutide effects on atrial fibrillation. And basically, this is for patients who have persistent atrial fibrillation who do have BMIs over 27, and they're seeking to undergo catheter ablation for treatment of atrial fibrillation. This is the essential design of the study. Patients at enrollment get randomized to one of two groups. One group is just standard risk factor modification. So we'll basically copy the program from Australia and try to reproduce that. The second group gets risk factor modification plus liraglutide. What's really unique about this trial is that we have a 3-month run-in period. So what we're using this for is what we call substrate stabilization. So we're try to treat the atrial myopathy before we actually do the ablation. So they get this for 3 months, then they get their ablation, and then treatment continues as outlined here. We do routine follow-up, and then the other testing that we do is CT to look at the change in epicardial fat. And we'll do serial echoes and blood for biomarkers, and then really looking at outcomes for atrial fibrillation. Again, the risk factor modification program really is designed to deal with weight, exercise, hyperlipidemia, sleep apnea, hypertension, diabetes, smoking, and alcohol. So these are really just standard things that we should all be doing anyways for our patients. So just as a sort of tantalizing teaser, this is some of our preliminary data so far. Just in terms of weight loss at 3 months, looking at risk factor modification and risk factor modification plus the liraglutide. You can see here with our risk factor modification, we get just over a little bit of a kilo loss. And with the liraglutide, we get almost 7 kilos, so kilograms. So it's certainly giving us a lot more bang for our buck in terms of weight. We do have the data on change in epicardial fat, but what's really exciting is I think we're starting to see the same thing that the Australians are seeing, is we've now had a couple patients that have been treated for 3 months in this pre-treatment window, and when it came time for the ablation, they were no longer having AFib, and they said, do I need my ablation anymore? So there are actually 2 patients that have gotten to that point and have not needed ablation. So we think that this actually may be a good therapeutic for patients with atrial fibrillation. And once again, just so to be clear that this is not only my opinion, the one thing that has changed in the most recent guidelines for atrial fibrillation, perhaps I think the only thing that has changed in the recent guidelines, is the addition of weight loss as a class 1 indication for treatment of atrial fibrillation. So you can see here for overweight and obese patients with atrial fibrillation, weight loss combined with risk factor modification is recommended. So this of all the things that have changed since the guidelines were last published in 2014, this is the only new advance, weight loss. So I hope that we'll be able to provide a little bit more information with the LEAF study. And certainly if you know of any patients that would qualify, please feel free to get in contact with me or with Carmen, our research nurse. So I hope I've given you all some questions to ponder. I think about these all the time. What is atrial fibrillation? What is atrial myopathy? And how do we treat the patient so that we can really affect good outcomes by treating either the atrial fibrillation, the myopathy, or both? And I think if you had to pick one or the other, my guess is we're going to end up treating the myopathy more than the atrial fibrillation. But time will tell. And I hope that provided you all some new insights into atrial fibrillation. So thank you for your attention, and I'll be happy to take some questions.
Dr. Goldberger, are you aware of anything going on to actually use these drugs just for weight loss in general? Because they seem to have a dramatic effect in obese people, regardless of having atrial fibrillation or not. And there are no effective therapies right now for obesity that are FDA approved, really.
Yeah, so Liraglutide is labeled for use for obesity. So that's how we're able to use it in this clinical trial,
Right.
because it's labeled for use in obesity. So our patients don't have to be diabetics.
Right.
And yeah, so it is available. I don't know how widespread its use is, but it is approved for that indication, and it certainly can be used.
Hey, Jeff, great talk. I remember years ago when you were giving the Louis Lamberg lecture, you mentioned, although this is kind of not the focus of your talk, you mentioned that regardless of AFib, at the time, you know, if a patient meets the CHAS-2 criteria, they need to be anticoagulated. You know, there were emerging data showing that. Has that ever changed?
Yeah. Yeah, no, I think so. That's a very good point. Yeah, and obviously I couldn't touch on all the topics related to atrial fibrillation, but the stroke risk for atrial fibrillation, we used to think was related to the atrial fibrillation itself, but there's now emerging data and more emerging data that the stroke risk is not so much related to atrial fibrillation, but is related to the degree of the underlying myopathy. And maybe what the CHADS-VASc score is telling you is it's giving you a grading for the degree of myopathy rather than the atrial fibrillation itself. So yeah, I think that's still a very, very important area of research, and there are a lot of important questions related to anticoagulation. But for many people with high CHADS-VASc scores who have had successful treatment for atrial fibrillation, standards are still to continue anticoagulation. All right, any other questions? All right, so we're right about 8:30.
I have one quick question.
Oh, Lisa, great.
Yes. This is always a challenge for me, just thinking about it. If we're, if persistent AFib, or let's say, I know there's some data that being in atrial fibrillation then can actually, as far as being the sort of chicken or egg in the sense of promoting more myopathy. In other words, is the myopathy only like what's happening at the cellular level, or is it also so does, I think there's data that staying in atrial fibrillation promotes more myopathy. So in that sense, eradicating the rhythm would also maybe lead to improvement in the myopathy. You know, there's maybe two reasons you have the myopathy, or, you know, a lot of these other risk factors, but also the rhythm itself promoting more, I don't know, distension, you know, irregular hemodynamics, et cetera, which also promotes myopathy. So I don't know, can you just comment on that just a little bit?
I think that's an excellent point, and I think Harold deals with that in this paper that he's that's coming out. But there's no question that just like we see tachycardia-related myopathy in the ventricle, right? That you're going to get a tachycardia-related myopathy in the atrium as well. I mean, again, you're activating the atria at very, very rapid rates, and you know, and we all know clinically, right, that once you've had somebody who's been in atrial fibrillation for 10 years, the chances that you can restore and maintain sinus rhythm are very low. So we know that there must be some progression of the myopathy that makes that to be the case. Yeah, so that's absolutely, I think, a very important thing to keep in the back of our minds. We don't have a lot of good. There are some data, but there's not a tremendous amount of data that looks specifically at that.
And then also with the LEAF trial, I assume, do you think that we'll be able to dissect out the role of just the pure weight loss versus decrease in epicardial fat?
So The answer is, it will depend on how much weight loss we can get in the other group, in the risk factor modification group. If we could, it's going to be hard to since we do see them both concomitantly, and I think even in the risk factor modification group, if they lose weight, their epicardial fat will drop. I don't know if we'll be able to tease that out.
Just one more question on people that are not overweight.
Thank you.
Dr.
Yes.
Goldberger, and people that are not overweight, do you think this might work also? Are there people who are not overweight who have epicardial fat, or maybe there's some other mechanism involved other than epicardial fat and the drug working? Because, you know, I see plenty of, you know, I see skinny people with AF. And do you think that it might be an option for them as well?
Yeah, so that's a great question. Obviously, everybody has epicardial fat, and you know, the epicardial fat store is not 100% correlated with body weight. So it is possible that, you know, the people who have AFib might have more epicardial fat than not be obese, and that may be responsible for their AFib. We are hopefully going to get funding from the NIH this coming year to do basically more of a screening study. It'll be focused on, it turns out that there are gender differences, and not gender, I meant racial differences in incidence of atrial fibrillation, and also incidences of epicardial fat. So for example, you know, blacks have less atrial fibrillation than whites. They also tend to have less epicardial fat than whites. So we're going to actually recruit, you know, blacks and whites in equal number with atrial fibrillation, and see if we take patients with if we select them for atrial fibrillation, does that eradicate the difference in epicardial fat? So it's sort of going to address that question that you're asking.
Right.
And obviously, if we do find that, then it becomes a potential target for treatment as well.
Hey Jeff, I remember years ago I heard this talk. I wasn't sure whether it's specific to epicardial fat or not, but nonetheless, there's good fat and bad fat. The good fat is brown fat. Does this matter with regard to AFib?
Yeah. So so the answer is yes. I mean, the epicardial fat does have important physiologic properties, and you know, that are positive, and you know, there are a whole list of those. But when it actually starts to grow in size, then it starts to have this pathologic problem. So it's sort of a double-edged sword.
Thanks.
All right, everyone, it's 8:35. Thank you so much for your attention, and thank you for your questions, and be happy to talk with anybody more about some of the intriguing stuff we're doing with atrial fibrillation. Have a nice day.
Thank you.
Thank you.
Thank you.
Great talk. Thank you.
Thanks. You too.
Thank you.